And so I was just talking to somebody who was telling me they had a family member that's in the hospital. The blood pressure was 230 something over 100 and something. So when you're approaching that level of hypertension, you're at risk for blood vessels rupturing in your brain. Other ways this can happen, some people might have, I know I had a family member this happened to, you might have little aneurysms, things like that. So basically little outpouches on the blood vessels in your brain, and that can be hereditary. And so if you have high blood pressure, that can predispose those to rupture, and that can cause a stroke as well. Okay, next slide. So this is just basically a picture of the different type of strokes. Okay, so on the left, you see how it's like they zoomed in, it's turning purple or blue up there. That's just showing that there's a cutoff right there, and that's not letting any blood get through to your brain. Okay, the other side is basically that blood vessel ruptured, blood is going where it's not supposed to, it's causing pressure in your brain. And both of these kind of can have pretty similar manifestations in terms of you not being able to speak, you having numbness and weakness throughout your body, things like that. Next slide. So 87% of the strokes are from ischemic strokes. So we talked a lot about diet. So that high-fat American diet that's full of red meat, you're full of salt, things like that, that's giving you more opportunities for your arteries to harden. You get plaque deposits in there, calcium deposits, things like that, and then they just break off and start flicking off into your brain, and then that causes little strokes like that. And you know, there's kind of little gradations of strokes, if you will. So you can have a huge, massive one where, you know, like you're not doing anything, you're not moving on one side, stuff like that. Or you can have what's called transient ischemic attacks. Or some people will say they had a light stroke, you know. So that's basically like a little bitty one went through, and you know, your body was able to compensate for that and get the blood around it, you know. So we talked about blood clots from the dietary sources. They can also come from your heart. So I know on TV they have a lot of commercials about AFib, or, you know, Brandon kind of talked about like his heart was like, he was on the energy drinks and his heart was feeling funny, having palpitations. So sometimes if you're having those funny heart rhythms and you staying in that funny heart rhythm and you don't detect it, your doctor doesn't figure it out, blood likes to not be stagnant. And so if you're having that funny heart rhythm, that blood will stay stagnant in your heart, and then it'll clot. Because if it's not moving, it'll clot. If you ever drop blood, seen blood on the ground, as soon as it's not moving, it's going to clot off, okay? And so that little bit of clot can shoot off to your brain and cause a stroke. Now, how many people in here think that strokes are a young person's or old person's disease? I have a brother that is younger than me that had a stroke because he had a funny heart rhythm. And he was doing all the things right. So he was actually in his house, in his gym, working out, trying to do the right thing. And all of a sudden he was like, I can't feel my face. I can't feel this side of my body. And so went to the hospital, figured out he had a stroke. Turns out he was having a funny heart rhythm, probably had it for years, didn't know about it, and that's what caused his stroke. So, next slide. So just a couple of things that I want you to remember in terms of like stroke symptomology and what to do if somebody has a stroke. And so the acronym is BFAST. So if you randomly start having balance problems, so that's your B. If you like lose sight in one of your eyes or both eyes unexpectedly, you know, vision changes, facial droop. Had a family member where he just kind of sat in the house and everybody was like, well, he just don't feel well. And his face had been drooping for days. Nobody noticed, and they finally took him to the hospital and was like, oh, well, he had a stroke. There's nothing really we can do to kind of like fix this now. Sudden weakness on one side of your body. You know, if you just like, all right, my right side is out, you know, I can't move, you know, I feel numb, stuff like that. slurred speech or losing the ability to speak, that's completely abnormal. And the last one is T. So that's time. So this is a two-part. So it's time to call 911. And it's also, I want you to remember that time is brain. So what does your brain need to function? Oxygen. So this organ right here, other than your kidneys, this organ right here uses the most oxygen in your whole body. Like, it can't go without oxygen. Your legs, you get a blood clot in your leg, you got like a couple of hours, you can make it to the hospital and fish it out. Your leg will be fine. This, you got about an hour. Probably even less than that. So, if you notice anybody, for the young people, if you notice somebody around you having these symptoms, and for the older people, if you see somebody around you having these symptoms, it's time for you to call 911. Next slide. So if you just click on the video, it's a YouTube video, this person is like, she's having a stroke in real time.
It was like at 6:42, and the sensation is happening again. Just smile, they said. Smile.
So look at the left side of her face. See how
it's all tingling on the left side. Like on the left side. The doctor said to breathe in, breathe out, man in distress. And I'm trying.
It sounds like she sounds
I don't know
like
why
her words
it's
are
happening
slowing,
to me.
slurring.
It happened this morning again. And when I left the hospital Monday night at like 12:30 in the morning. So now I'm taking a picture for an example of what happens. It's 6:43. My hand is hard to lift up.
So that's that weakness on that.
And she touched something, took my nose.
That's what it looked like.
Okay.
And see, she also lost some coordination as well. So sometimes, depending on where the stroke is, you might lose the ability to do simple things like this. Touch your nose, touch my finger, touch your nose. So that's some of the things when you come to the emergency department that the neurologists will have you doing. So next slide. So basically, your treatment, it changes depending on what type of stroke that you have. So first thing that's going to happen, you call 911, you're going to end up in Tenova. If you're up here, if it's really bad, I might see you down at Vanderbilt. You'll get a CT scan. So they'll get pictures of your brain and try to figure out exactly where that stroke is. We'll be telling you to wiggle your toes, do all these other stuff, just to, try to localize where it is as well. So you can get some IV medications. Now it's called TNK, so tenecteplase. And so basically they give you this IV injection over 10 minutes. And basically what that does is if it's a clot, it dissolves that clot and lets the blood get back in there, okay? The other part of this is if you see me, if you make it to the operating room, if it's a big enough stroke, they can go in through either your wrist or through your groin, and they can run some little wires up to your brain and they can pull that clot out. And so that's why it's really important for time for you to call 911 early if somebody's having these symptoms, because for these things, you can only do this within a 4-hour window to get the maximum recovery. So I've seen patients that go from, they came in, saw them, they couldn't do anything, and then they wake up and they're starting to wiggle their hands and stuff like that, and then about a week later, they're talking to you and look like almost nothing happened. You got a question, Brother Collins?
So, quick question. Now, in that meantime, while the person having a stroke, until the EMTs arrive, what can we do? Is there anything that we can do?
So I think the biggest thing is to make sure that the person is safe. So, making sure that they're, that they're not choking on anything, stuff like that, that they're breathing appropriately. I wouldn't recommend that you necessarily give them any medications or anything like that, because one of the big things with strokes is sometimes people have problems swallowing.
So do we, I know they said put something in it. I heard don't do it.
Yeah.
Put something so they won't bite their tongue.
So, so don't put anything hard in a person's mouth. If they're having a stroke or a seizure or anything like that, if they're biting their tongue, you could try to move it out of the way so that they won't damage it more. But, just make sure, just roll them onto their side. If they're like seizing, roll them onto their side, so that way if they throw up, nothing's coming down in their lungs, so that just comes all out. I wouldn't recommend giving them any aspirin or anything, because you don't know what type of stroke that they're having. And so if it's like, if it's a hemorrhagic stroke, if you give them aspirin, they're gonna bleed more. So I would say just keep them safe, make sure they're breathing okay, not, getting anything into their lungs, and wait until the EMS gets there. Yes, sir.
So in that case, I think the primary thing that you can do, other than keep them safe, is get them as quickly as possible to the medical people that can help.
Mm-hmm. Yes, sir. You have a question?
I actually, I was 45 when I had a stroke.
Mm-hmm.
And the stroke I had, my blood pressure was super high.
Mm-hmm.
When ambulance came, they actually put some cream on my chest and brought down
Yeah.
my blood
So,
pressure.
nitroglycerin, nitroplate paste. Mm-hmm.
And I was in the hospital for about a month total,
Mm-hmm.
with pig tube, all that stuff.
Yeah.
And there's really nothing you can do to get a person to the hospital.
Yeah. Yes, sir.
Question, I know we're talking about strokes,
Mm-hmm.
but how can you tell the difference between a seizure and a stroke, and is the procedures the same?
So it's not necessarily the same, but if it's a seizure, so a couple of different types of seizures. So sometimes people they call them colloquially grand mal seizures. So you see people shaking and stuff like that. They also have like absence seizures where they're having a seizure, but they're just not here. And so the big difference is if it's a seizure, the person, they might come back and they'll be a little bit sleepy, but eventually they come back to normal with no intervention. Yeah. With a stroke, they're just gonna be like, I still can't do anything, And usually most people, adults, you're not having seizures for the first time unless there's something wrong. So, you probably know if they had a history of seizures. But even if they're having a seizure for the first time, they should probably still go to the ED so they can figure out why they're having seizures. Because, yeah. No, that's a great question. Yes, sir.
Can you say a little bit about Bell's palsy? We don't hear a lot about that compared to a stroke. Is it a stroke or is it just something totally different?
So Bell's palsy is like usually either like inflammation or infection in the nerve, specifically the facial nerve. So that's basically one of the big nerves that's like right here on your face. And so if you get like a viral infection, so like a cold, HSV type 1, things like that, it can cause irritation in that nerve root and it just doesn't function properly. And so eventually with treatment, so like steroids, supportive treatment, eventually that inflammation goes down and you get that function back. Yes, sir.
So the question I'm asking is stress a factor into strokes?
It can be in the aspect of cause of driving high blood pressure, yes. So it wouldn't be the primary cause, but it can be like a contribution.
Well, one thing that I did have that was really weird, the day before I had the stroke, I was at work. And like you said, you just don't feel right. I was like, oh man, something ain't right. And the next morning, I woke up and I was sitting in the chair to get dressed to go to work. And I told my wife again, man, I just don't feel right. And I hit the floor and I couldn't get up. Then, that's when she called 911 and went to the hospital and whatnot. So So I kinda knew something was happening actual day before.
Yeah.
And then it really happened again the next morning. So and you know, a lot of people don't understand, I didn't feel, there's no pain.
Mm-hmm.
I didn't hurt at all. So there's no warning like my fingers hurt or something like that. Nothing hurted at all. I just couldn't move.
Yeah. Big part of that. So you think your brain is all nerves, right? Your brain actually can't feel anything. So it's pretty cool. So one of the surgeries that I do anesthesia for, that people have brain surgery awake. And so they'll be actually like taking parts out of the brain, stuff like that. They can't even tell. So, yes, sir.
Okay, we always talk about high blood. What about low blood? The other day, I think the line was 110 over 63 or 2 or something. What about that?
So low blood pressure can be a problem as well. So the way your body is set up, your brain pretty much tries to keep the blood supply to it pretty constant. And so if you fall outside of that range that your body likes to have it, you can, like, not necessarily a stroke, but you'll kind of pass out from a lack of blood to the brain. And so really that's your brain, your body trying to equilibrate, and you go flat, you get more burden of blood to your brain. So that's basically what's happening. Other things that can cause that, if you have cardiac problems, so if you have heart failure, stuff like that, that can cause that as well. Cool. So on the hemorrhagic strokes, so if you're on blood thinners or things like that, aspirin, whether you take warfarin, some of these other things that you might take for AFib, we'll reverse those things to kind of treat that, okay? Possibly maybe even surgery for these, where they go in, they can potentially like coil or clip blood vessels so that they're not bleeding into the brain anymore. So next slide, so stroke prevention. We talked a lot about this already. If you take blood pressure medication, please make sure that you take your blood pressure. If you have an Apple, if you have an iPhone, there's an app on there that you can put all your medications into, and it'll give you a schedule as to when you take your medications. It is very important for you to take your blood pressure medications as scheduled, as prescribed, okay? If you're on statins, if you have high cholesterol, you know, sometimes you could be doing all the right things for your diet, but you can still have high cholesterol. So if you're on a statin, make sure you're taking those that prevents that buildup from building up in your arteries. Take your blood thinners, aspirins, Xarelto, things like that. And also, if you're diabetic, make sure that that's well controlled. Several people mentioned that they were diabetic today and they got their A1C under control. And so basically that sugar, when you have too much sugar in your bloodstream, it deposits in your blood vessels and makes them not work the way that they're supposed to, okay? And that increases your risk for stroke. So keep that diet under control, keep the diabetes under control, and that kind of helps to prevent stroke as well. Next slide, stop smoking. Like, I mean, like people that's around me and they smoke, I tend to like, hey man, you just need to just stop doing that. There's so many things I had to learn in medical school because people smoke, and like they wouldn't have it literally if they didn't smoke. 30 minutes a day of exercise, at least. Brandon talked about that a lot. Lose weight if you're obese. Obesity is a pro-inflammatory condition. So what does that mean? So that inflammation makes you more likely to form blood clots. So lose weight. We talked about healthy diet, increase the fruits and vegetables. If you drink alcohol, I think a lot of my brother over here had mentioned he would eat a whole bag of cherries in one sitting. Everything in moderation. So if you're a male, if you do drink alcohol, no more than 2 alcoholic beverages a day. And also they can screen your carotid, see if you have anything there, if you have any plaques building up, and potentially that could be, they can be removed. Yes, sir.
Okay, got, two questions. One,
Got two questions. One, I heard that your heart really can't differentiate the difference between this. People who do workout can't really tell the difference between the muscle and fat, especially if you like bodybuilders, because your body still got to work hard to pump that blood through. And also, one situation for myself that you're talking about the clots. For me, I got tested, they did a stress test, and every time they said my heart don't pump out enough blood. So every time they do run the tube and everything through my arteries, they say I got a blockage, but well, from the scan when they run the data, they say I got a blockage, but when they actually run the camera, it's nothing there. What caused it? Because it happened twice already.
So a blockage in like one of your coronary arteries, or?
Last one was like, they call it the widowmaker,
Yeah.
but every time when they do run the dye, they say it's there, but when they do the camera, there's nothing there.
So it could be at the time that when they're doing the test, maybe you're having like a little bit of a spasm there. So sometimes blood vessels get irritated. They can just like clamp down randomly. That could be why it's happening, but you know, without more information, I couldn't really say exactly what that is. So if they're going in there and they're physically looking and they don't see anything, I'd be concerned, but not like thinking I'm gonna pass out like tomorrow or something like that. Because if there was a blockage, they would have put, especially with that particular artery, they would have put stents in or done something if it was like real, like a big deal, so.
so what about the situation with people being obese compared to,
So what about the situation with people being obese compared to people with a lot of muscle mass, with stress on the heart?
Well, I mean, yes, there is stress on the heart, but I also think that when you're obese, your heart is just not as well conditioned, you know, versus being somebody that exercises. Because, you know, your heart is a muscle, and aerobic exercise actually conditions your heart to be able to be more efficient at pumping blood, versus if you're not in shape, you know, for you to walk up a flight of stairs and you're not in shape, that could be like, you know, that's a whole workout for you, whereas a normal person, that's like, it's like, okay, I'm just going about my day. So I think there is a difference between the two, and, you know, I wouldn't say that it's beneficial for you to be obese, you know, because your body, eventually, your heart is gonna get tired against pushing against all that resistance, because if you're obese, you're more likely to have high blood pressure. We talked about that inflammation contributes to high blood pressure as well. So the longer your body has to pump against that, you know, the bigger your heart gets and the more likely it is to fail, so. All right, next slide. So we're gonna change pace right here. So that's 3 people up there that's famous. Some of the young people up there might only know one person, but I'll start in the middle. Anybody know who that is?
Strawberry?
All right, Darryl Strawberry. The young lady on the right, who is that? Cat lady. Catwoman. All right, and on the left, for the youngsters, who is that? Chadwick Boseman, the Black Panther. What do these 3 people have in common? They all had colon cancer. All 3 of them had colon cancer. Chadwick Boseman was younger than I am now when he had colon cancer and died. Darryl Strawberry was still actively playing for the Yankees when he had colon cancer. I mean, she was older, you know, but still, you know, I still think that, you know, colon cancer can be preventable. So next slide. So, yes, sir.
On the colon cancer. About the colon cancer, is that classified as hereditary?
It can be, and I'll talk about that a little bit later, if you let me get there. All right, next slide. All right, so what is the colon? So colon is also known as your large intestine. Why is it? It's funny, it's kind of, in some ways, kind of backwards. So your large intestine is 6 feet long. Your small intestine is like 22 feet long. But your large intestine, like the diameter, is actually larger than the small intestine, okay? And so what is it composed of? It's composed of some muscles. It's smooth muscles, so it's different than what's in your arms. But basically it helps in the digestion process. And so basically by the time all your food and everything breaks down and makes it to the colon, it's liquid. And the colon's job is to get a lot of that liquid out so that your stool forms into what you recognize in the toilet as stool, okay? It also gets electrolytes out of there, things like sodium, bicarbonate, stuff that your body needs. It also absorbs vitamins like vitamin B and vitamin K, which you need for energy and for blood clotting. So a lot of the heavy lifting in terms of your digestive tract has already happened before it got to your colon. But one thing that's pretty cool about the colon, and this is kind of where my PhD work kind of comes into play, is that your colon has a lot more bacteria in it than it actually has human cells. And so one of the researchers in my old department actually worked on colon cancer and basically found that when you eat like roughage, so you eat vegetables and stuff like that, the bacteria break down that into like small chain fatty acids, and those are actually some of the nutrients that give most of the nutrition to the cells in your colon. One of the things that colon cancer does is actually turns the transporter off, so it's not getting its normal nutrition. Next slide. So what is cancer? So basically cancer, just think about it as like normal cells that went haywire. So they can grow uncontrolled and spread to other parts of your body. They develop mutations in their DNA, and they grow when they shouldn't be growing. So your body is pretty smart. God did a pretty good job designing this thing, okay? And so it's signals that are sent out from other cells that tell cells like, okay, you can stop growing now. You know, you just kind of hang out and do your thing. But with cancer cells, they don't respond to those normal signals, and they don't like ignore boundaries. So like, you know, they'll like, suppose somebody tells you not to go through that door. Cancer doesn't care. It's like, I'm going through that door, I'm going wherever I want to, and it spreads all over, okay? It can cause abnormal blood cells to grow, blood vessels rather, so that, you know, it's like, all right, it gets bigger, it needs blood supply, so it can make blood vessels grow into the cancer to keep it growing. It can hide from your immune system. So your body is designed that if a cell becomes cancerous, your body should be able to destroy it. But the longer it hangs around, it won't be able to destroy it because it's hiding. And we talked about rapid growth. Next slide. So colon cancer is the third most common cancer in this country. African Americans are 20% more likely to develop colon cancer than other races in this country. And unfortunately, you're 40% more likely to die if you get colon cancer and you're African American. So why is that? So I talked about this a little bit earlier. So we talked about redlining, we talked about systemic racism. So for whatever reason, we're less likely to have the good insurance that'll let you get all your screenings. You're less likely to have a PC or a primary care doctor than other races. It's not because we can't find doctors. We might not be able to afford to go to the doctor, or you might not be able to take time off to go to the doctor, you know, so that you can take care of those things because you got to take care of your family. Lack of access to healthy food. So, yeah, I just kind of told you that, you know, eating more vegetables kind of helps you to prevent colon cancer because your colon likes to get its nutrition from the breakdown products of vegetables. But if you're eating all those foods that Brandon kind of talked about, where you can't pronounce the name, that's causing a pro-inflammatory state that's more likely to cause colon cancer at the back end. Lack of health education. So, I think this is a great thing that we do here. I commend Brother Fisher and Pastor Allen for doing this, but a lot of black men don't know about their body. So things will be happening, we don't talk about it in our family. Next thing you know, you're on your way out of here. Environmental factors, I grew up in Birmingham, my part of the city. I could see old iron ore mines from my house. My grandfather worked in the iron ore mine. You pretty much worked for U.S. Steel if you were in my neighborhood, So what's coming from the plant? Pollution, chemicals, stuff that don't need to be in your body that's potentially causing cancer down the road. Stigma. We talk about not really talking about things. Now let's just be real. A lot of men don't want to get screened for colon cancer because what the screening entails. So getting the colonoscopy is an invasive procedure. We're gonna talk about that a little bit later. A lot of people I don't want anybody back there. And some people be like, I would rather die than no. I think Brother Callahan kind of talked about some of this stuff, I'm a grown man, what are you gonna tell me? I'm gonna do whatever I want to. But your family is dependent on you. And you cutting your life short because you don't wanna know, because you wanna be, you wanna feed into stigmas and stereotypes and stuff like that. So we're gonna try to dispel some of that. So next slide. So some of the symptoms of colon cancer. So diarrhea or constipation, it could be either or. Changes in your stool consistency. So if I encourage you, if you don't look at it, look at it. Know what your stool looks like. If it goes from being loose, or it goes from being a regular size to all of a sudden it's like the size of a pencil, that's a problem. If you ever see blood in your stool, that is not normal. If you are a man, there's no reason why you should have blood in your stool. I'm not saying that it's always going to be colon cancer, but it's not normal, and you need to go see somebody. If you ever see bright red blood coming from your rectum, that is not normal. If you start suddenly having abdominal pain, cramping, bloating, gas, just changes from your normal bowel pattern, that could be a symptom of colon cancer. You go to the bathroom and feel like it never all comes out, that could be a symptom of colon cancer. Or you all of a sudden now you're weak and fatigued, or you losing weight, that could be all the signs of colon cancer because you're silently losing blood in your stool and now you're feeling weak. Iron deficiency anemia. So, kind of going through this with my dad right now. There's no reason for a man to be anemic. Women, they have a reason, childbearing age, they have a reason they might be anemic. But as a man, you have no reason why you should be anemic. So I always tell people, if you're anemic, and you're an adult male, it's cancer until we figure out that it's not cancer. Next slide. So colon cancer screenings. So we talked about the increases in colon cancer, not just in African Americans, but in this country in general. I can't say that I go on the news almost every other week on NPR, there's something about, more people are having colon cancer in this country. So the American Cancer Society has changed the screening age. It used to be 50, now it's 45. So I'm coming up, I'll be 44 this year, so I got about one more year before I have to have it. But, that also changes if you have a family history of colon cancer. So if your dad or uncle, somebody like that, had colon cancer and they were 50, you need to be getting screened at 40, okay? If you have a personal history of colon cancer, you need to be screened more often. If you have inflammatory bowel disease, so ulcerative colitis or Crohn's disease, you need to be screened more often because that puts you at a higher risk. So you kind of asked about like hereditary stuff. So there are certain genetic conditions where, you know, you have a mutation that like your DNA doesn't fix itself. And so that puts you at a higher risk of colon cancer. So those people start getting screened like in their 20s and 30s. So that's Lynch syndrome. If you ever been like irradiated to your abdomen for whatever reason, like, you know, not really common in this country, but if you lived around a nuclear power plant or maybe somebody in your family worked there, you might need to be screened a little bit more often. So a couple of different ways you can be screened for this. So there's basically, it's called a FIT test, and basically it just takes a little bit of stool, you put it on a card, it checks for colon cancer DNA, and then you get screened like that. That's non-invasive. Sigmoidoscopy, that just looks at like the first part of the colon. They usually don't put you to sleep for that. I don't think that's very common unless, you know, they're looking for something specifically. Colonoscopy, I would say, is the most common way that people in this country get screened for colon cancer. And so basically on that, next slide, sorry. So you'll see there's basically a little line that's going up. And so basically that's where that camera goes all the way around your whole colon to look for cancer and polyps, okay? And so as we go on to the next slide, so basically a colonoscopy is a long tube, it's a camera, and it's probably about half the size of this pew right here. And that's what they take and they look in there, okay? So your gastroenterologist can look around the whole colon. He's looking for polyps. He's looking for other things that look abnormal, any abnormal tissue, inflammation, things like that. And while they're in there, if you have polyps, they can go ahead and pull those out. Or if they see something that's abnormal, they can biopsy that, send that to pathology, and check and make sure that it's nothing concerning. Next slide. So, yes, sir.
Real quick, I might be getting mixed up. When do you get the finger? Is that what's checking the colon?
So that's prostate usually. Yeah. You can do the finger to look for hemorrhoids, but most commonly the prostate. And really they've gotten away from doing that. You can do like blood tests for prostate now. Yes, sir.
Okay, excuse me. I heard you say with like a father or uncle or whatever, as far as like if they had colon cancer, what about if it's your mother?
Yeah, so a first degree relative. So somebody that's like immediately related to you, if they had colon cancer, you know, you need to be having it 10 years, screening 10 years prior to the age they were diagnosed. So if it's like, say they had it at 43, 33. So, all right. So to me, so I've actually had a colonoscopy before. The worst part of it to me was the prep.
Come on.
They used to call it go lightly. I call it go heavily.
Yeah.
So basically, you take some laxative. It's gonna clean you out. You gotta watch your diet for a few days, you know, beforehand. You take that. It's really important for you to do the whole prep though, because it's nothing worse than them getting in there, seeing stool still in there, and be like, all right, you're gonna have to come back and do this again. So take all the prep. I did. It's hard. I finished one cup, it was time to go back to the toilet. It was not a good time. Don't eat anything that's red, you know, for a few days before the procedure because, you know, it might look like blood. You don't want to confound anything. So you'll get there on the morning of, you'll get changed into your gown, you'll meet your GI doc, sign some paperwork, you'll meet me, I ask you all about your medical history, and then you'll go back there, you'll get a little oxygen, get some medication through the IV, and then you're gonna wake up and it's over. Literally that, and you're gonna go home. Next slide. So the next slide is gonna be a video. You just see this guy's process as he went through.
See what it's like to get a colonoscopy screening. Colonoscopy screenings are important because they can prevent colorectal cancer from developing. Colonoscopy screenings are recommended for people age 45 and older who are at average risk of colon or rectal cancer. Your doctor may recommend you start screening sooner depending on your personal and family health history. Check out this colonoscopy experience so you know what to expect during your screening, and be proud of yourself for taking control of your digestive health. Step 1. Book your pre-colonoscopy consultation. Your colonoscopy screening experience starts by going online to New Health's Find a Doctor website. You can find a gastroenterology specialist near you and book an appointment online or request an appointment. Step 2. Meet with a gastroenterology specialist. You will first have a pre-colonoscopy consultation with a gastroenterology specialist to determine if you should have a colonoscopy screening. You may have your consultation in office or by phone or a telehealth visit. Step 3. Pre-colonoscopy preparation. Many people are worried about the prep before a colonoscopy because it requires you to drink a lot of laxative solution in water. We understand, but it is a critical step because the cleaner your colon, the better your gastroenterologist can see during the procedure. Thankfully, colonoscopy prep options have evolved, and most people tolerate the prep well. Your gastroenterologist will discuss prep options with you. In addition to the prep solution, you will need to follow a low residue or low fiber diet 3 days before the colonoscopy. Avoid foods such as nuts and seeds, raw fruits and vegetables, and whole grains. Aim to eat only white foods such as chicken, pasta, rice, and yogurt. You can also eat cooked vegetables. Then, 1 day before your colonoscopy, you will need to avoid eating solid foods. You can drink clear liquids such as water, sports drinks, black coffee or tea, lemonade, and light-colored juice. You can also have frozen treats, Jell-O, popsicles, and sorbet. It is important not to consume cream, milk, or red or purple liquids 1 day before your colonoscopy. Step 4. Arrive for your colonoscopy screening. You made it through the prep. Way to go. On the day of your colonoscopy, arrive at your appointment about 15 minutes early to check in. The person who accompanies you to your appointment can stay with you in the waiting room. Step 5. Pre-procedure meeting. In the pre-procedure room, you will change into a gown and secure your clothes and belongings in a bag that will stay with you during the procedure. Your gastroenterologist will meet with you to go over the procedure and answer any questions that you might have. An anesthesiologist or nurse anesthetist will also meet with you so you know what to expect before and after your procedure. Step 6. Get your colonoscopy screening. An entire team will monitor you during the colonoscopy to make sure you are comfortable and well cared for. After you're positioned on your side, the anesthesiologist or nurse anesthetist will administer a medication that will put you to sleep. It is as easy as counting down from 5. During the colonoscopy, your doctor will use a colonoscope to see the inside of your colon, also called the large intestine. A colonoscope is a thin, flexible tube with a light and video camera at the end of it. Your gastroenterologist will examine your colon on a monitor and look for abnormalities such as polyps. If your gastroenterologist sees a precancerous polyp, they can remove it using the colonoscope. A precancerous polyp is not cancer, but it could turn into cancer if left untreated. Step 7. Recover after colonoscopy screening. You'll wake up in a recovery room after the colonoscopy is over. The person who accompanied you can be with you in the recovery room. Your gastroenterologist will meet with you to talk about what they saw during the procedure. You might feel groggy from the anesthesia, so it is good to have someone else there who can also hear what the doctor says. You will be able to get dressed and walk, but you should not drive after the procedure. That's it. everything you need to know about having a colonoscopy screening. Learn more about colonoscopy screenings near you.
That's all I got for you today. If you got any more questions, I will gladly entertain them. Yeah. So it kind of depends. Yeah, it kind of depends on who you go to. Like different GI docs use different preps. So yeah, a lot of people are moving towards just like taking a couple of pills. I took a couple of pills and I had a drink. So yeah. Yeah. But again, you know, this is one of the things that you can talk to your doctor about, you know, y'all, this is all a collaborative relationship, you know. This isn't the doctor telling, like, you do this, you know. You gotta work together to make this thing work so that you stay healthy.
I like to thank the doctor for what he said. It's a saying that you never really realize till it comes close home to you. Saying that my father died of colon cancer at a young age of 64. So us talking, it was like, y'all need to get checked. I'm ready to get checked. And my thing was, something you mentioned, I'm not finna get violated like that. Going back to what you said, pride is a big thing that'll mess you up. Or I would say it's a lie. I gotta think about it. If you did do this, well, how long you gonna last? Just in case something happens. So my thing to say that is no shame to your manhood or nothing to better yourself and get yourself together. So I thank you for even bringing that even up.
In regards to your, with high blood pressure, I have a friend that's a pharmacist. I would tell her what I'm taking, and she would make a note and say, hey, a lot of the medication that you're taking is for white people, first off and foremost. Have your doctor suggest this, because it's been proven to be more effective in the black population. Can you elaborate on that? Yeah,
so the one that comes to mind is specifically is lisinopril. So it's more likely to cause, so it can cause a cough. And it's more likely to cause the cough in African Americans. It's kind of dose dependent as well. So it's kind of one of those things where it's like you have to, a lot of times in medicine, you have to weigh the risk and benefits of a particular treatment. Because one of the great things about that drug is if you're diabetic specifically, it actually helps to protect your kidneys. And so again, you know, I always say that it's a team effort. These are things you have to talk to your doctor about, you know. And so when I'm on high blood pressure medication. So when I talk to my doctor, it's like, I mean, I'm a doctor too, but I don't do family medicine, you know. So we have a pretty good professional conversation, and I'm like, all right, well, I want to try this, and she's like, okay, yeah, I agree, that'll work for you, you know. So I would say it's kind of annoying when people say they do their research, because to me it's like people take that as like, I did my research so I know more than you. Like, you should be going to your doctor like, I did my research on these things, and like, what do you think? I think we should try this. What do you think in your professional opinion? You know, you want to be an informed patient, but, you know, also realize that I done spent like 20 years of my life learning how to do this, you know. So I think that's another reason why I kind of recommend. So I went to Meharry. You we talk, I feel like at Meharry, we spend a lot of time talking about these things and how treatments may differ or how to approach the African-American patient different than we do like at med school at Vanderbilt. So I recommend if you can find an African-American doctor, hire one. If you can't, it's fine, but have those conversations with your doctor about, I found this, and this medication might work a little bit better in my population. What are your thoughts, or why aren't we doing it this way? I think we have one over here. You can come back.
Question on prostate. So I had a prostate exam not too long ago, and I was amazed when my doctor told me that we don't do it the way we used to do it.
Yeah. We
just do it like a visual. Mm-hmm. And I was curious how they were able to determine whether you were negative or positive, as opposed to what the finger was doing versus what the eyes were doing. And that was my first question. My other one is, I just wanted to say to everybody, I can't stress the importance of having a personal physician. If you don't have one, find one, and seek one out, and gain that relationship. A lot of us will just go to urgent care, or they'll just go to the doctor, but find you someone that you can go to regularly. My doctor was looking at my spinal cord and was just taking x-rays because I hadn't had x-rays since '95, so she needed a full workup. But because of that careness of wanting to get that full, she found cancer on my kidney, and we caught it early and we're able to address it. But had I not had a personal physician, who knows when that would have been discovered? It might have been too late. So I just stress with everybody, if you don't have a primary care physician, start working on finding one, Thank you.
So regarding the prostate thing, so like I said, we're trying to move more towards like non-invasive testing, so just going more towards the blood test. So with the finger, the problem is you can only feel like that part of the prostate that's close to the rectum. You can't necessarily figure out what's on the other side. Whereas if you do the blood test, what's in there is in there. And so they spent a lot of time doing these studies and, doing research. I know research kind of has a bad connotation in our community. When doing research to, okay, we compared this to this and found that like doing the blood test is more effective. You find more cancer doing the blood test versus doing it the old-fashioned way. So that's kind of why we moved away from that. Yes, sir.
I know you said not to go in, you can do your research, but I was always puzzled at how you watch TV and it's getting more and more now. This medicine pops up. And it's like, I'm not a doctor, but it's like they're trying to tell you what to go tell you. Apparently, buy us, use us. And it's like, I was like, that, to me, they just probably shouldn't even do that because it's just,
that's only legal in America.
Yeah, it's not like Lay's potato chips. I mean, I can't just go try it in the store. It has to be prescribed for me and whatever. But I'm like, why do they keep doing it? I figured the only reason is so you can go in and try to tell your doctor.
It's money.
Yeah.
It's 100% money. Because like I said, if you go to other countries and go to Europe and stuff like that, they can't advertise for medications like that overseas. So it's all, that's a whole separate conversation about, how the healthcare industry is driven by insurance, and people always try to make it seem like, oh, well, the doctor's making all this money, and that's why my healthcare is high. Actually, no. If you look at like statistically how much money physicians make versus the administrative people in medicine, like we just like a little slice of the pie. All the money is mostly going towards admin and insurance costs, not us. But that's a different conversation. Yes, sir.
Yes, I heard you say something about the Cinepril, and it helped, by me being diabetic, it's supposed to help filter my kidneys and everything. Well, they had an adverse reaction with me. It gave me an angioedema.
Yep.
So I thought I was just having an allergic reaction to something I might have ate or drunk or whatever. And my whole face right here, it blew up. And I was like, and as soon as I went to Sango ER. The doctor asked me, "Are you on lisinopril?" I'm like, "Yeah." He said, "You're not no more.
Yeah.
I'm taking you off of it," but they haven't found anything to substitute it except to filter my kidneys or anything, because I wasn't having high blood pressure. I was just taking it to filter my kidneys. So I was like, that was just crazy to me, because it had never happened. I had been on lisinopril for ever since like 2017, and last year I had that adverse reaction.
Yeah, it's not like in terms of like being an allergic reaction where you take it and it happens right then. So that can happen at any time if you're in your life, if you're on it. So it's not common, but it's a known side effect of that medication. So.
What are your thoughts on like natural supplements?
All right.
Real quick, I'm diabetic too, and I've been struggling for maybe the last 4 years. Doctors put me on and off of different medications and having just negative reactions to different medications. It's very frustrating. So this last time, like you said, we tried to do our own research. I was able to get my A1C from 12.5 to 8.5.
Good.
But it's like I said, I'm doing a little bit of medication, but then some supplements too. I asked my doctor this last time, what do rich people do? Because there's no way we can keep taking all this medicine.
Well, the rich people, it's diet. I will tell you that. Food is medicine. But as far as supplements, I don't have a problem with supplements. The problem with supplements is that they're not well regulated. And so the most recent one, so I know a lot of people take, like you can take cinnamon, that's supposed to help with diabetes, but they also had like a recent problem where there was like too much lead in cinnamon. And so that was causing lead poisoning, which could cause its own problems as well. So the problem with supplements is not that what's supposed to be in there doesn't work. It's just you don't really know what's in there because that's not regulated by anybody. So.
One of the, I have more so a comment in reference to what the gentleman said over there about being a primary care doctor. When I retired from the military, I had TRICARE had me get a civilian doctor. And brothers, what we gotta do is pay attention to what that doctor does to you. One, he smoked. I should have known, that was a red flag. Two, his appointments, you'd be there for hours waiting on him. He was super late. And the first, I got sick. One time he was in the office, he said, "Oh, he reading the stuff." He said, "You know you had a stroke, right?" I said, "Well, no, I didn't know that." How did I have a stroke? And he didn't give me no blood test, no nothing. After that, so he didn't prescribe nothing to me. You know, it's almost like, man, I gotta get rid of this guy right here. He's gonna kill me. You know, so you really, there's red flags that you should see. It's like, man, is this guy doing this? And what's happening right here? Like I said, he smoked. I should have knew it right off the bat. You know, but you know, it's just things like that. You know, you gotta pay attention to.
Yeah, I will say, you know, I got bad habits too, but you know, one thing that I try to do is lead by example. So, you know, after all these years of medical training, you know, and honestly, not taking care of myself because I was trying to take care of everybody else, you know, I got out of shape and, you know, my blood pressure got high, but, you know, I went to my doctor and she was like, "Oh, your A1C is creeping up." I'm like, okay, it's time to get right. So what did I do? Brother Lewis, who was up here, I hired him as my personal trainer immediately. So because I was in the Army too, so when I got out to go to med school, like I was still in pretty good shape. But you know, 8 years of ignoring yourself so you can take care of people, you know, is not healthy. And my story is not unique because, you know, when you're a resident, they call it a resident because you live in the hospital. You're a resident of the hospital. So I was in there, like it would be some type of days where literally I'd be in the hospital 24 hours. just in the hospital. That's not counting me getting home, you know. So what's the easiest thing to do? Man, I'm gonna get me some Waffle House on the way home, eat some Waffle House, then I'm gonna take me a nap, you know, and you know, next thing you know, you 215 pounds. I'm like, man, why my suit not fitting? You know, but yeah, you gotta, you know, look out for those people that's, you know, trying to do the right thing themselves, that's trying to give you advice. And, you know, and also, just because you have a physician, you're not married to that person. If you feel like this person is not serving your needs, find somebody else that's on your insurance that takes care of you the way you feel like you should be taken care of.
Can you hit up on the use of prescriptions as far as doctors? You go in for one thing and you gotta leave there with 4 or 5 prescriptions. And I've been told that they make money off of them. And, you know, I know they, you know, I'm not saying they don't care, but, you know, you go for one thing and then you leave out of there with a handful of prescriptions on the and it goes back to knowing your primary care physician, but, you know, it's not good to just take just medicine all the time.
Yeah. So, in most cases, I wouldn't say that you get paid for prescribing anything. I give a lot of propofol, so the medication that put people to sleep, I don't get no kickback from that. When I write prescriptions for people that need something in the community, I don't get a kickback from that. I don't see anything from that. So, as far as why you might go for one thing and end up with several different things, to me, it kind of seems, you know, you don't just, if you have a good physician, you don't want to just, I'm going to treat you for this one thing, and then you can come back and see me for the other problem later, you know. So if I see that you have high blood pressure and your cholesterol is high and you're diabetic, which one do you want me to treat first? Or do you want me to treat them all at the same time? So, you know, I can't speak to your specific situation, but, you know, I think that, you know, if you come to see your PCP and they're like, okay, I've noticed that you have all of these problems, this is what we're gonna address, I'm gonna take it as they're trying to take care of all of the problems instead of trying to nickel and dime. Because, you know, part of the problem is because of the insurance thing, and he kind of alluded to it, having to, you know, technically, you get paid as a primary care doctor, like your slots are like 15 minutes. And so, like when I was in med school, it's like, all right, if you're gonna do primary care, you gotta pick a couple of things and work on them, and then I'll come back, I'll see you for the rest of the stuff later. So that's things that you know, that's not because the physician wants to do that. That's how insurance is dictating how you get paid. Now you can be like, all right, I'm gonna do 30 minutes appointments and make less money. But usually the freedom of that comes if you have your own practice. So if you're working for somebody like Tenova, they're gonna be like, these are your 15 appointments, and this is how 15-minute appointments, and this is how many people you have to see today. So I think part of it, but to get back to your original question, I think a lot of that is trying to be efficient and trying to give you the most bang for your buck that they can give you while they have the time to take care of you.
A quick question, besides the bright red blood in your stool, if you see like any other symptoms, how long could you wait to go get seen unless like something you don't think is, or maybe you think it's cancer if I'm bloated or something like that? It's like wait till you get these number symptoms before you get seen for that.
I would say that if you notice anything that's out of the ordinary for you, don't go to, I'm not saying go to the emergency room, but schedule an appointment, you know, so that, you know, because it could be, you know, it could be you're just lactose intolerant. It could be a lot of other things. But if you notice something that's out of the norm for you, you know, make an appointment, in, be seen by your primary, and if it's something that they can't handle, then they can refer you to the person that can handle it. Cause I know how TRICARE works, they want you to come see your primary, then go see them, then they'll refer you. Other insurances, you don't necessarily have to do that, but, yeah.
I know, weight is a big factor in high blood pressure. What are your recommendations to help some of us, that are already on the high blood pressure medicine, try to get off of it? Like, what should, I know he gave us things to eat, like the red meat and stuff like that, but as a doctor, what are your recommendations outside of what he gave us?
Yeah, I'm gonna say, so when somebody comes in with high blood pressure, the first thing we're gonna do is say diet and exercise. So you need to be exercising at least 30 minutes a day. As far as your food, be cautious of things that we talked about a little bit about hidden sugar, hidden salt is a big problem.